Welcome back to the Am I Mental podcast, the Doctors in Court edition. My name is Dr. Sabine Fonderson. Today, I'll be exploring a case that really emphasizes the importance of proactive care. As always, the names are fictional to respect everyone's privacy, but the case itself is real. So let's dive into the story of Dr. Whitfield and his patient, Mr. Eli. He's an elderly gentleman with complex health issues. Today, I'll talk you through what happened, from the timeline to the complaints that was filed, the defense's arguments, and finally, the disciplinary board's decision. I'll also unpack some key insights on managing complex cases in primary care. Let's start with a look at Mr. Eli's medical background and how things unfolded. Mr. Eli was 78 years old and he's originally from Azerbaijan and has been living in a care facility at that time. He had diabetes, previous strokes, and had developed what's commonly known as a diabetic foot. This condition, as some of you might know, means that even small wounds can turn into huge problems without proper care. In April of 2007, Dr. Whitfield saw Mr. Eli for dry, open wounds between his toes. He prescribed an antifungal cream and advised the home care team to keep an eye on the wounds. Everything seemed under control for a while. But then in October, new wounds appeared. The staff at the care facility informed Dr. Whitfield, who then consulted with the wound care nurse and updated the care plan. He also told the home team care to notify him if things got worse. And initially, it looked like the treatment was working. By November, the wounds seemed to be healing. But in December, during a routine visit, Dr. Whitfield noticed that the wounds were actually worsening. He adjusted the treatment plan again, and on January the 4th, after hearing that there was no improvement, he prescribed a stronger antifungal and moisturizing gel. Then in mid-January, Mr. Eli's wife expressed concerns about the care he was receiving from the home care team. She decided to take over wound care herself with guidance from Dr. Whitfield. However, the wounds continued to worsen, and by the end of January, Dr. Whitfield referred Mr. Eli to a vascular surgeon, hoping a specialist could provide more intensive treatment. Unfortunately, by March, Mr. Eli's condition had significantly deteriorated. He was admitted to the hospital, where he underwent multiple surgeries that led to amputations. He passed away in April due to complications from the infection. Now, after Mr. Eli's death, his wife filed a complaint against Dr. Whitfield. She argued that he had delayed referring her husband to a specialist and should have acted sooner when the wounds kept recurring. She also claimed that Dr. Whitfield didn't do enough to ensure the home care team followed his instructions. Her view was that he didn't check in often enough, especially when the wounds seemed to be getting worse. And she felt that his approach was too reactive, waiting for issues to arise rather than taking proactive steps to manage her husband's care. And this, in her view, contributed to the progression of his wounds and ultimately his death. In his defense, Dr. Whitfield stated that he had acted within reasonable medical standards. He pointed out that he had visited Mr. Eli regularly, adjusted treatments as needed, and consulted with both the wound care nurse and the vascular surgeon as soon as it became clear that Mr. Eli's wounds weren't healing. He also mentioned that he had given clear instructions to the home care team and to Mrs. Eli when she took over wound care. He felt he had done everything in his power to manage the situation, given Mr. Eli's complex health issues and the logistical challenges of coordinating with the home care team. Another point in his defense was that Mr. Eli's underlying conditions, such as diabetes and previous strokes, put him at a higher risk of complications, which could have influenced the course of his illness no matter what approach Dr. Whitfield had taken. After hearing both sides, the disciplinary board concluded that Dr. Whitfield had indeed fallen short in a few areas. They felt that he hadn't acted with enough urgency, particularly given Mr. Eli's high-risk profile with diabetes and the diabetic foot condition. The board noted that, especially in cases like these, a more hands-on approach is essential. They found that Dr. Whitfield's reliance on the home care team, while understandable, wasn't enough. They suggested he should have personally followed up more frequently and kept a closer watch on how the wound care was progressing. The board issued a formal warning to Dr. Whitfield, reminding him of the importance of proactive and detailed documentation, especially in high-risk cases. They emphasized that while the home care team plays an important role, the primary physician must maintain oversight and accountability. Let's take a moment to dive deeper into what can be learned from this case. Managing patients with complex conditions like diabetic foot requires a proactive approach, especially when they're high risk, as Mr. Eli was. And while coordinating with home care teams is crucial, it's also essential for primary care physicians to maintain direct oversight. This means not only giving instructions, but also checking in on the follow-ups. Documentation is another big takeaway here. In Mr. Eli's case, the board pointed out that Dr. Whitfield's records were limited, which made it harder to track his care plan's progression. Accurate and detailed documentation could have helped coordinate care better and possibly highlighted sooner that Mr. Eli's condition was declining. Another lesson is about the importance of family involvement. While Mrs. Eli took on some of the wound care duties, it might have helped to involve her in discussions about how serious diabetic foot can become and ensure she knew the signs of worsening conditions. Education and communication are key in managing care inside and outside the clinic. And this case highlights how important it is to treat high-risk patients like Mr. Eli with extra caution, ensuring that they're not just getting the minimum they really receive, but that they get the proactive care that is needed in order to prevent escalation. What is the main key of diabetes and wound healing? In an article published in Medicina in 2021 by Burgess and colleagues, Diabetic Wound Healing Science, they explored the complex mechanisms involved in diabetic wound healing and the increased risks that patients with diabetes face regarding wound complication, particularly diabetic foot ulcers. This condition affects 25% of people with diabetes, and it's often challenging to manage due to multiple factors, for example, impaired angiogenesis, neuropathy, and chronic inflammation, and all of these contribute to delayed or non-healing of the wounds. There are key factors in diabetic wound healing. First of all, hypoglycemia and angiogenesis. Chronic high blood sugar levels lead to poor blood flow, and that affects wound healing by reducing nutrients and oxygen supply to affected tissues. And impaired angiogenesis, or blood vessel formation, is a major issue in diabetic wounds, making healing slower and increasing the risks of complications. A second factor is neuropathy. Many diabetic patients experience sensory neuropathy, leading to a lack of sensation in extremities. This can result in unnoticed injuries that worsen without immediate treatment. So, for example, they don't feel pain that they normally would or wounds on their feet. Motor and autonomic neuropathies also contribute to wound complications by reducing skin resilience and moisture that leads to cracks and infections. The third factor in diabetic wound healing is chronic inflammatory response. Diabetic wounds often remain in a prolonged inflammatory state, preventing normal healing processes. Excessive inflammation leads to tissue damage, and that can invite infections, complications, and in all, just complicating wound management. The fourth factor in diabetic wound healing is the barrier function and infection. Now, the diabetic skin barrier is weakened and it makes it more prone to infections. And diabetic wounds often host complex biofilms of bacteria, which further inhibit healing and can result in severe infections requiring aggressive treatment. All in all, patients with diabetes and wounds are extremely challenging to manage. And in the case of Mr. Eli in this episode, these insights are crucial to understand why his wounds deteriorated and the risk associated with his diabetic condition. Unfortunately, Dr. Whitfield, his physician at the time, did not recognize the need for earlier aggressive interventions based on these complications, which are really commonly seen in diabetic patients. The review that I just summarized emphasizes the importance of early identification and intensive management of diabetic wounds. And physicians treating patients with diabetes should closely monitor wounds, especially those on the feet, and proactively coordinate with specialized care teams. Technically, early referral to wound care specialists or vascular surgeons, as well as involving family members in wound care education, are the mainstay of management, and it's going to be critical in avoiding severe complications. Okay, so I'm going to wrap up this episode and leave you with 2 questions to reflect on, and I'll give you my insights on those questions. Here's the first one. What are some practical ways that primary care providers can keep better track of wound care for high-risk patients? Well, you need to detail. So documentation is really important. Frequent check-ins, not only with the patient, the family, but especially with wound care experts. So there's a difference between a home care team and a wound care nurse. And in this case, the doctor involved, Dr. Whitfield, should have sought expertise from somebody who really specializes in wound care, particularly in diabetic patients. It's a completely different form of management and it requires frequent check-ins. So that's really one of the important things. And monitoring all these aspects of wound care is really important in order to make sure that if there's any signs of decline, they are frequently then referred to hospitals, because this cannot be managed at home. Here's another question to reflect on. How can family members be more effectively involved in a high-risk patient's care plan? Well, a lot of family members are typically happy to be involved in taking care of their loved ones. The high risk associated with it means that as a physician, you need to be able to instruct them better, educate them better on warning signs that empowers them to play an active role in preventing complications. So the family members should be made aware what to look out for when things get worse. And they should be the ones contacting the doctor to either come and see the patient, come up with a new treatment plan, or in this case, for example, refer the patient immediately for specialist care. So yes, family members are extremely important in the patient's care plan, but the moment that the high-risk patient is involved, as a physician, it's really important to have extra expertise in this care treatment plan so that the family members can rely on expertise from others and also from the doctors who can monitor and oversee the care. In this episode, I explored the case of a doctor and his high-risk patient, and I also looked at the challenges of wound care and the importance of proactive management in primary care. The key lessons are that managing complex cases is extremely challenging, but it's important as a physician to coordinate well with various care experts, not only home care teams, but wound care experts, in order to prevent complications. So tune in for an insightful discussion next time, and thank you very much for listening to this episode. Thank you.